Hi, Steve. I'm very glad that you're here because you've been in education for 30 so years, and I think that you have a lot of experience in educating endodontists and general practitioners.
Great to be here, and I've been looking forward to coming and visiting Greece for a long time, and so it's been really fun.
Now, in the last few years, there are many changes in the field of dentistry with the coming of many bone grafting techniques and the implant dentistry. Do you think that as endodontists, we should relocate the specialty of endodontics in the new map of dentistry?
First thing I'd say is the demise of endodontics was a little bit premature. And I remember 5-8 years ago when everybody was saying, endo's done, it's all implants are better, they last longer. It was interesting because recently the Italian Prosthodontic Association in Rome, Italy, voted on would they rather restore an endodontically treated tooth or spend the time and the money to put an implant in and restore that, and the majority of them voted for endo. Now this is with the understanding that these are Italian endodontists treating the cases for those prosthodontists. So the prosthodontists are answering their preference based on the fact that it almost always works because these guys are phenomenal and they do a great job. The difference between well done endo and poorly done endo is of course a huge difference in outcomes, and restorative dentist viewpoint on how predictable endo is as a procedure depends on the quality of endo that's being done. It's a one-to-one relationship.
Do you think that adhesive technology has helped us a lot to save more teeth from cracking?
I think the lecturer before me at this meeting, Stefan Pohl, said it really well. Adhesives don't chemically bond to dentin. There's a mechanical lock into the irregularities of the etched dentin, and so that's great. Having a mechanical undercut is even better. We talked about the advantages of being more conservative and endo access, which leaves pulp horns laterally that help lock the bonded composite in. However, the one thing he did say was nothing makes up for a good ferrule. Okay, a good ferrule, at least 1.5 millimeters, preferably 2 to 2.5 millimeters below the edge of the sound tooth part of the dentin, is more important than post length, than bonding technology. That's the whole deal. So even though our adhesive materials are creating better seals and better longevity on our buildups, if you have an anterior tooth that's broken off the gum line, if it was my tooth, I'm still going to choose an implant.
What do you believe are the advances in our specialty that have made the difference?
The past advances have been primarily taking the conceptual requirements that Herb Schilder laid down for us in treating the whole root canal system and creating tapered preparations, using hypochlorite effectively, doing three-dimensional obturation. We've just become more adept at delivering those services. So the concept hasn't changed over the 30 years I've been in practice, but the ability to do that has become much quicker, procedurally, easier to train, fewer instruments for each of the procedures, and that's been fantastic. Where we're headed in the future is this is already in the present time, but it's in the future sense that it's rolling out. It's an expensive technology, and so it's going to take a while for more of us to have these. But I honestly believe that practicing endodontics, especially without a cone beam CT machine, is just a way harder way to do it. The kind of cases that we see are so difficult. We see so many endodontic failures that can be difficult to see on conventional radiographs in terms of, is there a fracture, where's the bone missing, what kind of treatment plan would we have compared to endo versus doing implant surgery, how much grafting would have to be done. But beyond that, the high resolution machines like mine, the J. Merita, Accutomo, and VeriView Epoch 3, they're showing us lateral canals. And so now when I head into a tooth, and I have these for every tooth I treat, I never have to guess how many canals are there, where the hidden curves are. I see all the hidden curves, I see all the canals, I know if they anastomose and branch, and as I said, quite often I can tell if there's an accessory canal nearby. That has changed my practice, if possible, more than bringing microscopes in did. It's unbelievable. And I had it for about 11 months, using it on the difficult cases before I realized with the low radiation these machines dish out, there's no rationale not to use them in all my cases. And I charge my patients probably about the price for a Panorex. I don't charge them a full CT fee if it's not needed for the diagnosis or the treatment plan, because literally it makes my job easier. I can get the case done faster, and my CT machine pays for itself every month I have it. So that's the current trend and revolution going on. Future trends, future technologies that are not quite here yet but are being rolled out as we speak are the use of rotary files for negotiation. We always said, okay, rotary shaping is fantastic. It's shortened our times by 40 minutes in a tough canal, and instead of 18 instruments, we're using 1 or 2 or 3 at the worst. But we always said you need to negotiate the canal by hand. And I accepted that, and I had that belief system until one of my friends, Fabio Gorni, recommended that I try using some of the small, like an S1 Pro taper. In the US, we have these new Vortex files by Tulsa Dentsply. And remarkably, the 1506s and 1504s go to length in probably 80–90% of the cases with no hand instruments whatsoever. I expected this would cause a blockage. I would have challenges with breakage of files. I haven't seen it. I've seen less chance of blockage. I think I've seen more lateral canals cleaned out and filled at the end of it, because I'm just making this up because I can't see in there, but I'm envisioning that using our push-pull filing action that we've used for hand negotiation is pushing debris into the accessory canal orifices, and we use this augering motion of the file rotating with a helical path. It's literally pulling or extirpating the pulp off the dental walls, leaving a cleaner surface for our hypochlorite to act on later. So that's been phenomenal. And we also have in the market already are the path files by Dentsply Myofor. These are very tiny instruments that I don't use in most cases, but if my 1506, 1504 doesn't get to length, then I'm going to bring in the path files, which have small tip diameters of a 13, 16, and a 19 with a square cross section and a O2 taper prep. These files are incredible for dilacerations. In your cases, you have so many great, wildly curved canals. I think you're going to really enjoy these. And what the Italians have told me, the guys that introduced these and designed them, Elio Baruti, Arnaldo Castellucci, and Giuseppe Canatori, these guys have some of the best curved canal cases I've seen besides yours. And basically, they reported that they had cases they couldn't get hand files around, an 06 or an 08, and when they put one of these 13s in, they got around the curves that a smaller file didn't want to go around by hand. And I thought, well, you guys designed the files. I think you're a little biased. That can't be true. Turns out it's true. I've had many cases of doing an extracted tooth exercise and getting a little frustrated and then saying, well, let's see what happens with the path file. I put the small one in and bang, it goes to length where the 08 didn't want to go. So as often happens, we see the technology change in unexpected ways, meaning that sometimes new files come out and they're designed for a use that turns out to be a little bit different than the way we find them to work ideally. And sometimes the uses that we find for them are far beyond what the manufacturer, the instrument designer actually conceived of when they designed the file. And rotary negotiation is one of those issues. So that's really exciting. That's been the hardest part of my molar treatment routine since everything else has become pretty much automated and straightforward.
Which areas do you think that endodontists and general practitioners should focus their education? What do they need more to learn about the procedure of endodontics?
That's a great question, because most of the people who come to Santa Barbara to take my hands-on course come because they want to learn how to use the newest rotary files, the newest filling technique, because that's kind of the glory work, and we love doing that. But almost all of them leave saying the most important things that they learned were improvement of their access cavities, their ability to find MB2 canals and upper molars, for instance, and more predictable negotiating techniques that are going to allow them to get to the end of all the root canals they find. And it's ironic because we argue about a lot of things in procedural endodontics that are so secondary to this topic of, if you can't find all the canals, you can't negotiate them to their terminal points and avoid blockage, it doesn't matter how sophisticated your shaping or filling techniques are, they're not going to work that often. So these are fundamental. If you get these fundamental issues, the start of the procedure done right, almost, I want to say anything, almost anything you do after that, regardless of which files you use, which exact filling technique that you use, that doesn't matter as much as did you find all the canals, did you negotiate them predictably to their terminal points, or using an apex locator so you have total control of your length the whole time. These are so far more important than the things that follow. It's not even funny. One thing I would also like to add to the future of endodontics riff is, so rotary negotiation is currently happening. We have files that are allowing us to do that. New instruments will be designed now that we understand that this is a really valuable direction to head in. So that's very cool, and it's really nice because being an upper second molar, as you know, as an endodontist, you're in there all day long, and you're in one more second molar. There's limited space, and being able to put a handpiece-driven file into an MB2 is so much easier than having your fingers on the file and you can't see it with your mirror angle. In a handpiece, it's a cinch. You get a catch with your Explorer, and if you get that little tug back sense, then you take your file, rotate it in there. It either goes in or it doesn't. If it goes in, you're there. If it does, you know you need to use your ultrasonics and cut a deeper groove to look for that. The other thing that is more in the future tense, but I've started to see some research and hear more about it, is the laser activation of irrigating solutions. And the problem with lasers in endo has been that most of the laser use is in the hands of general dentists, some of the periodontists, but not using them the way that we would use them. And so because of the vast majority of lasers being used by general dentists, they're not oriented to generating research. They're typically not in an academic environment. And so for endodontists to say, hey, I'm going to go buy a $50,000 or $60,000 laser, they're going to have to see some serious research results that show this is superior. And it hasn't existed yet. You talk to the BioLase and some of the laser companies, and you come away thinking like, these guys are salespeople, and I don't believe anything they're saying, and you're probably right not to. Now I'm hearing some clinicians tell me and show me some SEM imaging that shows really effective. The cool thing about it is the early uses of laser to clean canals out was not in the presence of hypochlorite. It was in a dry canal after it's shaped, and you would slide the fiber to the end of the root canal, move it back and forth. This is totally different. Basically, it's used now to pulse energy into the sodium hypochlorite in the same conceptual way that you would activate it with an ultrasonic device. But unlike an ultrasonic device, you don't have to put it in the canal. If you have the solution filling the canals that are shaped to the pulp chamber, you just put the tip of this in the solution in the pulp chamber. The energy field through there is tremendous, and all the way to the end of the root canal, it seems. We'll know more about it, but if in fact I can clean a tissue out of an accessory canal in a minute instead of 25 or 40 minutes as we currently have it, I'd pop for the laser. I'd spend the money. Yeah, but I think I'm really hoping that comes to pass, because with all the advances in all the other areas of endodontics, the one area that's always been the redheaded stepchild and really not paid attention to is the successful irrigation of root canals.
I want to thank you for having you here, and I am very glad that you mentioned all these areas of education that the dentists need to know about and to learn more. And I am very glad that since you are so experienced, now you have the experience not only to teach basic things, but to teach things that they do really need and they should focus on. Because so far, we were oriented more on techniques and not on strategies, not on principles of endodontics. I want to thank you one more time.
I totally agree. My pleasure. It's great being with you.